Good morning, everyone, or good afternoon, depending on where you're located. And welcome to our webinar that's focused on approved and investigational treatments for ATTR amyloidosis, both hereditary and wild type. All our previous webinars can be viewed on the webinar section of our website, amyloidosissupport.org, and on our YouTube channel. And this webinar should be up there and available in about a week or two. In the control room today, we have ASG's Executive Director, Paula Schmitt.
Hi, everyone.
And our Special Projects Director, Bob Gibson.
Hello, everybody.
Paula will join us later to talk about financial aid, and Bob will also be sharing some updates on our patient registry. Oh, by the way, I'm Muriel Finkel, President and co-founder of Amyloidosis Support Groups. Our esteemed panelists today include Dr. Nitasha Sarswat, the University of Chicago, Dr. Matt Maurer from Columbia, and Dr. Chafic Karam from the University of Pennsylvania, along with Monica Fawzy Bryant from Triage Health. I do want to remind everyone about 3 upcoming in-person meetings that we're going to be hosting. The Cincinnati meeting on September 19th, Boston meeting on October 3rd, and a Chicago meeting on October 17th. Details can be found on our website or email me at muriel@amyloidosissupport.org. We'll be working off our treatment chart today, and Bob is putting it on your screen for your reference. You can feel free to email me at muriel@amyloidosissupport.org for your own copy. And we find this makes it easy. You don't have to worry about how do I spell these things. You can just look it up and see the treatments that our doctors are referencing. Okay, so with all that done, and we will now ask Dr. Sarswat to give us a little overview on the current approved treatments for ATTR amyloidosis. So Dr. Sarswat, take it away.
Hi, everyone. I'm just going to share my slides. Okay. So what we're going to talk about are just the currently approved treatments, and then Dr. Maurer is going to talk to you a lot about our clinical trials. So we'll kind of talk through what is actually FDA approved specific to TTR. So I like to show this slide first just to give you a sense of kind of where we are historically. I've been pretty deep in the amyloid field, I would say, for about the last 15 years. And boy, have we seen a change. But I think it gives you a really good sense of how much progress we're making and how much active research there is out there. So you may hear, we really only have good 3 FDA approved treatments for cardiomyopathy, plus another for neuropathy, but good for you guys to realize, like, I mean, 7, 8 years ago, we had absolutely nothing, and it was a whole different ball game. And so we're really making a lot of progress. These are the trials that have happened in the last 10 to 15 years. And those trials are really what help us advance and got these drugs FDA approved to try to help you. So I think it just gives you a nice sense of where we are as a field and that we still have a lot more to learn, but we're making fast progress, which is great. So when we talk about the TTR protein, I want to take you back to high school science, and it's important actually because this is how we actually developed the drugs and how the drugs were made. So the TTR, transthyretin protein, is a tetramer. It is made in the liver. So the liver makes the messenger RNA. That messenger RNA kind of encodes for what makes the protein. The protein itself is a tetramer, which means it has 4 different parts to it. Those 4 different parts can separate out and then fall apart into what we call monomers. I've heard Muriel give this analogy, and I like to use it a lot with my own patients, that the tetramer itself is like a 4-leaf clover that then falls apart into 1-leaf clovers. Those 1-leaf clovers are all folded abnormally and then bunched together and then like to deposit all over the body, but often the 2 most common things and where really the drugs are aimed right now are at the cardiomyopathy and at the neuropathy part, which includes autonomic dysfunction and autonomic neuropathy. Now, when we take apart kind of that underlying biology, again, this is how we've made the medications. So if we look at where the protein or the mRNA is made in the liver, we have a few different things. So there's a gene editing trial that Dr. Maurer, I'm sure we'll talk about. And then we have drugs that actually bind to that messenger RNA. These are what we call those silencers. Those silencers are vutrisiran, patisiran, and eplontersen. Vutrisiran, also known as Amvuttra, right? Patisiran is Onpattro and eplontersen is Wainua. And how those work is really binding to that messenger RNA. So about 85% of the protein is just not made. And when it's not made, it can obviously deposit in parts of the body and then cause harm to the tissue, whether it's the heart or the nerves, or even theoretically the carpal tunnel and all of the other places in the body that those proteins can form. Then the next set of drugs, what we call stabilizers, really help keep that protein in a four-leaf clover, right? So they bind to different parts of that tetramer and prevent it from falling apart. And those are three medications that we'll talk about: tafamidis, or Vindamax as you may know it, acoramidis or Attruby, and diflunisal, which is something that we use often off-label. And then where we're headed is medications that help remove the amyloid fibrils. And these are all still clinical trials, but we have some good hope here. So we've really gone from a state when 7 years ago we had no treatments at all to a point where we've now developed multiple FDA-approved therapies that slow progression, and now potentially medications that reverse the disease itself, which is amazing progress again in the last 7 years or so. So we're just going to walk through a couple of these different medications and talk through them. So the first one that was FDA approved is tafamidis, or you may hear Vindamax. This is a trial that Dr. Maurer ran and was published in 2018 called the ATTRACT trial, if you hear about it. And in that trial, people either got the drug or they got placebo, and there were two different doses of the drug that were studied. And what we really saw at that point was people live longer, right? And this is a chart that just shows kind of, really somewhere around maybe here around the 15-month part, people started living longer than the people who got placebo. And those of you who participated often in clinical trials, or some people do it just in their normal clinic, we do a 6-minute walk test, which just shows how far can you walk in 6 minutes. And we really saw that the people that were getting the medication versus the placebo could walk farther. Now, obviously, there's lots of things that prevent people from walking: shortness of breath, fatigue, joint pain, leg fatigue, lots of different things. But on the whole, overall, the people that got the medication could walk farther, which to me is a very big sense of quality of life. When I'm seeing somebody in clinic, can you walk in from the parking lot to get to my office, right? Are you able to keep up with grandchildren as you're running around after them? And then there's the KCCQ, which is, again, is just a sense of quality of life. Those of you, again, in clinical trials might have filled out this little form that talks about what you're able to do, how you feel like your quality of life is, which again is very subjective, but that's actually the point. And what we saw is that people that got the medication versus placebo had a better quality of life. So to me, this is kind of hit all of the things. Not only does it make you live longer, but I don't want to just live longer. I want to have a good quality of life if I'm going to live longer. So we really saw that, and we saw that with what we call a number needed to treat of 7, which means that for every 7 patients I give the medication to, I'll at least save one person. So that's pretty good odds. That's better than what we say for aspirin in the setting of a heart attack. Then came along the next stabilizer called acoramidis, or you'll hear it called by the drug companies as Attruby. And you see those commercials on TV with Morgan Freeman. I can't tell you how many patients walk into my clinic every day and say, give me that Morgan Freeman drug. So he's clearly doing a good job of their marketing. But acoramidis is a similar drug to the one we just talked about. It does stabilize that 4-leaf clover in 2 spots instead of 1. And in the trial, we saw a lot of the same types of things. We saw people live longer. We saw them not getting hospitalized as often, which is, again, wonderful, that you're out of the hospital spending time with your family. And we saw, and kind of came to light, where we potentially can follow serum or blood levels of how much protein is normal. And what we saw is that when you go on drug, there was a lot more kind of normal protein, that you live longer again, and that you stay out of the hospital. So again, a very good medication that improves quality of life and makes you live longer. This was FDA approved in November of 2024. So several years after the first drug that was approved in 2019. And I can't tell you that one drug is better than another. We do see a lot of the same effects. They are both overall really good medications with minimal side effects. We do see some occasional diarrhea with the second one, with Attruby or acoramidis. Truthfully, in my experience, I don't find that it happens very often, but it is certainly reported and something to be aware of. Acoramidis, again, we see these we follow pre-albumin levels, and we see that even within like 30 days, we see an improvement in the amount of TTR. And we know that this is helpful both in hereditary and wild type. Then the third kind of stabilizer is something called diflunisal. I always tell patients this is like an old school NSAID, right? Like what you would take for pain. And we do think it binds and stabilizes that TTR tetramer in the same way, but just like taking a lot of ibuprofen, we worry about side effects like GI bleeding, extra fluid retention, worsening blood pressure. Truthfully, we don't see a ton of that in clinical practice, but what we think is this is a medication that, again, off-label, there are no big clinical trials because this is a drug that's cheap and easy, that we think can work well as a stabilizer. We use them lots of times in people who have the gene variant but don't have the disease potentially, and has honestly been quite safe in that case. There are times, and I think this is very rare, that for financial reasons or other things, that if you can't get on the normal medications, that we use diflunisal. Honestly, I think that becomes a pretty rare case at this point. And again, we worry about heart failure, so it tends to be people that are certainly on the healthier side. Then came the silencers. So the first silencer, again, these were those medications that bind to the messenger RNAs and prevent the protein from being made. Patisiran was an IV medication that we give every 3 months. We don't use it very often anymore because now we have a newer drug, but patisiran is a good drug that was approved for hereditary neuropathy. We looked at it for cardiomyopathy as well, and it didn't meet its first endpoint, partly because I think we showed the data a little bit too early, but in the end does seem like it has a good benefit for cardiomyopathy as well. Regardless, then came on the next drug, and this drug is FDA approved right now for both hereditary and wild type cardiomyopathy and neuropathy. Vutrisiran is an injection that we can give in any subcutaneous tissue, so in the belly or in the arm every 3 months. Most patients are still getting it in infusion centers, which is kind of silly because it takes 2 seconds in an infusion center. And the big trial that we always talk about is the HELIOS-B trial. The HELIOS-B trial looked at patients who, some of which, about 40% of which, were also on a stabilizer, tafamidis at that point. And people, same thing, lived longer, stayed out of the hospital, had an overall quality of life benefit. What we didn't see was a huge benefit to the people that were already on tafamidis and then got put on vutrisiran, and that's really important to know. We also didn't see a harm with that combination therapy, but I can't look you in the eyes and say that you're going to get a huge benefit to being on both at this point. So those are the FDA approved treatments that we have at this point for the cardiomyopathy.
Thank you so much. That was lots of information in a short amount of time. That was super, Dr. Sarswat. And remember that the recording will be up there, so we'll be able to all hear it again a second time. With my learning curve, I have to hear things 3 times before it clicks in. So, okay, thank you. And now we're going to hear about clinical trials, investigational drugs, and we're going to hear that from Dr. Maurer. So, Dr. Maurer, take it away.
Great. Okay. So nice to be with everyone. Hope everyone's enjoying the warm weather and staying a little cool. So these are trials that are currently ongoing and recruiting. These are not all ongoing clinical trials. Some have finished enrollment. So I thought I would focus on the ones that at least I'm aware of. As Nitasha said, Dr. Sarswat, there's a rapid evolution in the field. And so it's often impossible to keep track of all the current trials. But we'll talk about Triton, CM, and PN, which is using a drug called nuclesiran. We'll talk about Magnitude, which is the gene editing trial using CRISPR. We'll talk about ACT Early, which is a prevention trial, and using acoramidis to prevent the development of the disease in people who are carriers of a variant but don't yet have any, what we call phenotype, any evidence of organ involvement. And then we'll talk about Cleopatra, which is a study using a monoclonal antibody to try to remove amyloid that's actively recruiting. I am aware of a lot of really brilliant young investigators. I don't know how young these folks are anymore. Sarah Cuddy and Parag Goyal, I mentioned these two studies. These are what we call investigator-initiated studies in which Dr. Cuddy is studying exercise training, which I think is wholly underutilized in patients and would be a huge benefit. I often tell my patients, don't spend money coming to see me, go get a trainer or somebody. That's a better use of your money. And Dr. Goyal has been interested in this idea that what we call N of 1 trials, where every one patient is their own control, and they, they're very individualized. But this idea of beta blockers being potentially harmful in amyloid, he's doing a study in which he has patients carefully withdraw their beta blocker and see how they feel, and then they make a decision at the end. So if they're interested, I can connect people to any of these folks who are doing investigator-initiated trials. So nuclesiran is a next generation silencer made by Alnylam. It's the compound that's, one up from vutrisiran or Amvuttra that we heard about that's FDA approved. This is a siRNA silencer, and these are the phase 1 data in which they showed the drug worked at various dosages. And you can see the different knockdown or reduction in the serum TTR. And the trial, there are 2 large trials ongoing now in ATTR PN, polyneuropathy. Dr. Chafic can tell us more a little bit about that trial run by the Neurologist. And we have an ATTR CM trial that probably will finish enrollment quite soon, is my sense. In the next few months, it was designed to recruit over 1,700 patients in this particular trial, in which patients, 2 out of 3 receive active drug, and unfortunately 1 could receive placebo, and that is usually on top of a standard of care therapy, which obviously is a stabilizer in this case. So exciting data. This is a drug that's administered every 6 months, not every 3 months like Amvuttra. Next up is gene editing. So it's another way to silence the TTR protein, but this is so-called one and done. These are data that were published in the New England Journal of Medicine, initially in the first 6 subjects. That's how excited people were, only 6 subjects, and they reported the data. And then there was a subsequent publication in 2024 about the first 36 people who were treated. This is an IV infusion you can see here of a single lipid nanoparticle. The lipid brings the contents inside to the liver, and inside is a TTR specific guide. So it brings the scissor here, this is the CRISPR-Cas9, to the right spot on your chromosome number 18 in the hepatocyte and cuts the gene right at that spot, leading to, as you can see here, marked reductions in TTR levels that are greater than 90%. And there's very little, if you will, heterogeneity amongst patients. These little error bars show that almost everyone had greater than 90% knockdown. This was an open label study, initially a phase 2 study done at the National Amyloid Center in London, and they reported data on 36 patients. And here you can see they're looking at NT-proBNP levels over time, troponin levels over time, and the KCCQ score, which is a quality of life score, and the 6-minute hall walk that we saw. I would point out, of these 36 patients, half of them had NYHA class 3 symptoms. So this cohort seems sicker than what we're used to seeing in the other trials. And despite that, again, open label, so we have no comparator, the NT-proBNP, troponin, quality of life measures, and 6-minute hall walk were quite stable. They also showed in these subjects that there were changes in what's called global longitudinal strain. That's the shortening of the myocardium, where greater shortening is an improvement, and the changes in extracellular volume. Higher extracellular volume up here is worse. Less extracellular volume is better. And they saw in these what we call waterfall plots, with each one of these bars being a subject, that there were improvements in how the heart was shortening, and improvements, it looks like, in the amyloid load in these subjects in this trial that was open label. The trial that's ongoing is called Magnitude. It's a phase 3 randomized trial, similar to the one I mentioned of Triton. that use nucresiran. This trial is also randomizing patients 2 to 1. So out of every 3 subjects, 2 get active drug, 1 gets placebo. And there are criteria that I won't go through. We should note that there was a safety signal that emerged during this trial. All of these trials are monitored by an independent data and safety monitoring committee that makes sure that subjects are not put at risk. And there were concerns about liver toxicity from the agent. And the trial was paused while the sponsor figured that out and what the problems were. They now have a mitigation strategy. And excitingly, they figured out the patients who are likely to develop liver abnormalities. When they say likely, the chance is about 10%, and patients who are very unlikely to develop liver test abnormalities. And that's important in the informed consent process. And the pause of this trial has been lifted. And at many sites, including ours, we're actively enrolling people in this particular trial if they're eligible. Act early is moving toward the less extreme arm of the disease, not people who have obvious what we call phenotypes, that they don't have cardiac involvement or nerve involvement, but they have a genetic predisposition to the disease, and their families seem to develop the condition around the age that they are right now or within 10 years. That age is the predicted age of disease onset, or what people call PADO, P-A-D-O, and in subjects who meet the criteria for the study, who are, God forbid, close to the time when their particular gene is likely to cause a problem or it happened in their family, they can be randomized to receive therapy or not. This is 1-to-1, in which you receive atrubie or acoramidis or placebo, and we follow patients for the development of the condition. Quite exciting, I would say, and we're moving from treatment to preventing this particular disease. This is another agent that is currently being used. It's called coramitug. There's a trial that we heard about of a drug called clearamitug, or NI-006, also known as ALX2220, because every time they shift the company, they rename them. But that trial is fully enrolled and there are no spots available. We're waiting to see the outcomes of that trial. Coramitug is being studied in a trial called Cleopatra. It's an antibody, you can see kind of marked up here in blue, that doesn't bind to the intact normal tetrameric TTR, but does bind to the misfolded pieces, and in theory activates cells in your body called macrophages, which are like Pac-Man, and they can chew up or eat up the amyloid that is present in various organs. We did do a phase 2 trial. This was a randomized trial in a small number of subjects. You can see here 35 got placebo, 35 got a high dose of coramitug at 60 milligrams per kilo of body weight, and 34 got a lower dose. And in this particular trial, there were 2 endpoints that were primary: how far people walked after a year and what their NT-proBNPs did. The walking test did not differ between the 3 groups, but you can see here that the blue, which is the high dose, had a 48% lower NT-proBNP compared with the placebo group, which suggested some disease modifying activity of the drug. All of these patients were also taking stabilizers. And there were echoes that were done on the subjects and significant effects that were seen favorable on various parameters of the left and right ventricle and even the atrium in these particular subjects. So encouraging, and this is now being studied in a trial that's called Cleopatra. It's a trial that seeks to enroll about 1,300 patients who have TTR amyloid variant or wild type, but they must have an NT-proBNP over 1,000 as per the entry criteria. So earlier patients aren't being included. And this is a 1-to-1 randomization of this dose of the drug, antibody or placebo. The antibody trials are not as infrequent visits as the other trials. These are IV infusions on a monthly basis that usually always have to start at the center where you're receiving the therapy. And then if things go well and there are no adverse reactions, and essentially I haven't seen any serious adverse reactions, then patients in many of the trials are allowed to transition to get the infusion in a blinded way, but in their home every month. That makes it a little bit easier. And these are what we call event-driven trials. So when someone asks me how long is it going to last, I do not know. But on average, these trials last 3 to 4 years. So I'll stop there. I don't know, Muriel, if we should go on to the next section or take any questions about treatment at this point, whatever you prefer.
Well, we will be taking questions at the end, okay? Because we've got a lot to go through. But and people are typing in questions, which we really appreciate. But right now, I I want to grab Monica Bryant while she's with us, and from Triage Health, because I've been looking forward to talking to her and asking her some questions for the longest time. And so many of our patients are so grateful that we have Monica and Triage Health in our life. So we want to thank you. So I just have a few basic questions. Okay, 'cause I know you're a lawyer, and most of the people that work at Triage Health are lawyers. And here you are, a nonprofit, and you're not charging for your services. And we all know, lawyers are supposed to be sharks, and you're not a shark. So, what brings you people to want to start a nonprofit to advocate for patients who are ill?
Well, thank you so much for having me here today. Really, what happened was the co-founder, Joanna Duran, and myself realized that so many of the barriers to access to care, things like being able to find a specialist, or what do you do when an insurance company says no, those issues have answers in the law, but people have to be able to understand what the law says and then know what practical next steps to take. And we don't think that people shouldn't get access to care because they're not lawyers. And that's really what brought us to do this work, is to make sure that everyone has the answers that they need so that they can get the care they need.
Now, when I first met you, you were called Triage Cancer. And I assumed that people in your family or your co-founders' families had cancer, had some issues, perhaps. But now you're Triage Health as well. So can you kind of give us a little of that metamorphosis there?
Absolutely. So the organization is still called Triage Cancer. We are a cancer organization at our heart. And really, the co-founder and myself are, in fact, sisters. And our parents were oncology healthcare professionals. And so we've always sort of been in the oncology space. But over the many, many years of doing this, wonderful humans like yourself would come to us and say, listen, we work with patients that have this other condition or this other diagnosis. Would you still come and talk to our groups about health insurance and employment rights? And we always, of course, said yes, because we're never going to gatekeep that information. But then we would tell hundreds of people, go back to our website for more information, where of course everything said cancer. And the feedback we got is that people felt like it wasn't for them because they didn't have cancer. They had another diagnosis. And so in 2023, we launched a program called Triage Health, where we're providing all of the same free legal and practical information, but not specific to a particular diagnosis.
Wonderful. We're so grateful you're doing that. Now, our amyloidosis patients are mostly adults with issues about life on the job, Social Security disability, Medicare, Medicaid, caregivers, life insurance, health insurance. What can for those people who are not familiar with you, what can Triage Health offer them?
So those are all the issues that we try to teach people about. And when we try to give people, the information about various options they might have, and then an understanding of the pros and cons of particular options. And we do that through events. We host webinars and conferences that anyone is welcome to join. We have materials on our website in a variety of formats. We have a podcast and written materials and animated videos. And then we also have a legal and financial navigation program where people can come to us with their specific questions, and we will have a phone call with them to try to explain their options. So we're never going to be someone's lawyer, like we won't represent them in court, for example. But most of the time, people don't really need a lawyer. They just need the information about what the law says. And so anyone who is interested can visit us at triagehealth.org. to learn more or to sign up for any of those free events.
If someone has an individual issue that has not been shown in one of your webinars or one of your podcasts, and they would like to have a one-on-one free,
Yes.
Is there a way they can do that?
Yes, so that's that legal and financial navigation program. So if you go to triagehealth.org/gethelp, there's a form that you can fill out. Tell us a little bit about your situation and your question. Once someone submits the form, they'll get a link back in their email with a calendar that they can then pick the time that is convenient for them. We'll give them a call at that time and we'll try to walk through their various questions.
Oh, that is so great to hear. Now, something that always comes up every year during the certain end of the year is, when they have open enrollment. There's Medicare, Medicaid, Marketplace, which is better? What do I do? And I know you guys are great on that. You have webinars. Tell us a little bit about what's going to be coming up at the end of the year now for our people.
So you're absolutely right. Every year we have open enrollment, and that's the opportunity for people to sort of reassess their health insurance coverage. Maybe they need to pick differently because there's a specialist that they want to see that's not in their current plans network. But we are in a pretty unique time right now based on some laws that were passed last year and some rules that have been issued out of CMS and HHS. We're going to have some pretty significant changes to access to health insurance within Marketplace and Medicaid and Medicare. And so we're still waiting on some states to make some decisions. We're waiting on some court cases that might come out. But we at Triage Health will be hosting a webinar on October 1st, totally free to attend. Anyone is welcome. All you have to do is sign up on our website. But on that October 1st webinar, we're really going to be trying to highlight the things that patients and caregivers need to know before enrolling for 2027.
So that's October 1st, a really, really important webinar. Well, we do mention all of your webinars when we send out our emails, but if you send us the link to that, I'll be sure and get that out to everyone that's on this call as well, because this is so important. And we can't thank you enough. There might be some more questions for you. Can you hang around in case there are?
So I can hang around for about a half an hour, but I'm absolutely happy to type them in the Q&A.
Oh, that would be great. If you could just type in the Monica questions, that would be wonderful. Thank you so much.
Thank you so much for your partnership. Appreciate it.
Okay. And now, Dr. Maurer, you're going to tell us all about cardiac symptom management.
I think it's going to be myself and Dr. Sarswat who are going to tackle this together.
Okay.
Let's see if I can find the right spot. There we go. Everyone can see the slides? Okay. So Nitasha and I kind of quickly prepared a little talk, but this is really, I think, important. These are the most common symptoms that at least my patients in the cardiac realm talk to me about. So I have to say, I think I probably should have trained as an orthopedist lately, because many of my patients have much more common complaints related to orthopedic manifestations. But fatigue is by far and away, I'd say, the most common symptom. Also effort intolerance. Fatigue to me is kind of a post-exertional construct. I did something and I was tired. Effort intolerance is almost like you're doing things and you're short of breath doing them. There's trouble sleeping. Patients need, God forbid, to prop their head up more and more with pillows. That's why we ask about that. That's called orthopnea. Not using pillows for comfort, but because if you didn't use them, you would have trouble breathing. And God forbid you get into real pickle, you could end up with a rapid onset at night of shortness of breath. That's what paroxysmal nocturnal dyspnea is. And often patients complain of frequent urination at night. It's actually potentially related to the fact, in my experience, that your cardiac output might improve when you lie down, and sometimes even the diuretics kick in. There's a lot of bloating, pants getting tighter, needing to loosen the belt buckle, or lower extremity edema. Patients complain of palpitations and often say they're dizzy, particularly when they change positions, get up quickly. That's called orthostatic, which is change in position, low blood pressure, or hypotension. And if it's really that or other symptoms related to dizziness or severe, people can actually lose consciousness. Any of these could prompt you to speak to your clinician, but I would say that if you're really having marked changes in your effort tolerance, you can't do as much, gaining a lot of weight quickly, or God forbid, passed out, those are reasons not to wait till your next visit to speak to your doctor, but tell them that those symptoms are ongoing. I don't know, Nitasha, things to add?
The only thing I would add, I think, people hear the word heart failure, the term heart failure, and often get very taken aback and scared. And a lot of these are symptoms of heart failure. And heart failure is just a syndrome where you have a tendency to feel tired and short of breath. And potentially retain fluid. And I know that it sounds like a very scary term, but it's just a lot of these symptoms. Now, certainly we're hoping to catch you before you get all of these things, but these are definitely things to talk about because they are all signs that something is progressing and that you have heart involvement that has led to heart failure. Not everybody with heart involvement has heart failure and has all of these symptoms, but this is what we hear.
Yeah, that's great. Thanks. And as I mentioned, Nitasha just mentioned, heart failure and common atrial fibrillation, abnormal heart rhythm common, and slow heart rates. There are a whole host of musculoskeletal manifestations that are shown here. And to be honest, my sense is that the current available therapies don't really ameliorate many of those. We haven't really studied whether they slow them or change their natural history, and they're treated very similarly, whether you have amyloid or not, to how someone manages spinal stenosis regularly, which is, physical therapy, medications for pain management, anti-inflammatories cautiously, epidurals, and God forbid, if really needed, an effective surgery. We'll hear more from our neurological colleague about polyneuropathy and the manifestations. And autonomic symptoms are quite, I might say, prevalent. These are autonomic, meaning they happen automatically. You don't tell your body to do them. So when you stand up out of a chair, more blood moves because of gravity into your legs, and your body has to adjust using certain reflexes that make the heart pump harder or faster. They constrict the veins in order to prevent the blood pressure from going too low, and that doesn't work so well in patients with amyloid. I don't tell my body to take the piece of chocolate I just had and move it through my intestinal tract. It kind of does it automatically. That can not happen very well in patients with amyloid, resulting in alterations in gut motility and constipation, weight loss, or diarrhea. And certain automatic things like getting an erection can also be altered. Nitasha, anything to add?
The only other thing that I'll say that I think we're still very much learning, and I mean, Phil, I'd love to hear your thoughts on this, is the joint involvement, right? I think so many times when I have people that already have known amyloidosis and they go for hip surgery or knee surgery, and we ask the surgeon to take a little piece of tissue, we almost always certainly find it. So I think there's still a lot there that we have to learn. And I think the only other point I was going to make is a lot of those musculoskeletal things that Dr. Maurer was just talking about often happen well before we see the cardiac manifestations, and that's where we're really moving it as a field, is to try and catch patients when they have either autonomic dysfunction or, I mean, certainly if they have polyneuropathy, that I would say is still later, but carpal tunnel and all the tendon issues, we're trying to screen people and catch them before they get any of those cardiac manifestations is the goal.
Yeah, I couldn't agree more. We have a large NIH-funded study now at 5 sites in which we're taking patients who had previous lumbar spinal surgery over the last 20 years. We asked them for permission to study their specimens that are in the pathology department in the freezer. We send them all to the Mayo Clinic. We've enrolled almost 800 subjects, and 45% or some odd have amyloid in their spine. And we then invite those patients who know and knew they could have amyloid in for screening to see if we can better ascertain the condition earlier. So exciting research, and I completely agree with Dr. Sarswat that the orthopedic manifestations are being leveraged to find people early, like variant carriers that we talked about before. So I won't go into all the management details, but just some highlight a few things. Many patients with amyloid develop in the middle there. Atrial fibrillation, if you do, you need to be on a blood thinner, no matter what other risk factors you have, because the risk of, God forbid, having a stroke is high. The management of atrial fibrillation is very individualized, and there are many patients who go into AFib and don't notice it, and they're told by their provider that they're in AFib. I'm less concerned about them, but if it has a significant impact on one's symptoms and ability to do things, then there are all sorts of treatment paradigms. And as people are diagnosed earlier, we're becoming, I think, more aggressive with approaches such as ablation. Many patients end up with significant slow heart rates, what we call conduction disease in the upper right corner, and need a pacemaker. And there may be a preferential reason to put a certain type of pacemaker in called a cardiac resynchronization pacemaker. Thankfully, most patients with amyloid in the bottom right do not have a major risk from ventricular arrhythmias for passing away suddenly. And so we don't usually recommend in all patients a defibrillator. Certainly, God forbid, if someone did have an event that was tied to a fast heart rate where they passed out, lost consciousness, or needed to be resuscitated, we would recommend a defibrillator. That's called secondary prevention. Aortic stenosis is not uncommon in amyloid patients, and if it gets worse to being needed to be treated, we often treat it with a percutaneous approach, not surgery, called a TAVR. And then, as Dr. Sarswat was saying, most of the time we spend managing the bottom left corner there, which is heart failure, asking you to limit your salt intake, weigh yourself every day as part of your disease management program, which could be cumbersome. We use as little diuretics as possible, and not on this list, interestingly, and when this was published, is the role for drugs called SGLT2 inhibitors, which we'll talk about. Nitasha, things to add?
No, I think that's great.
Yeah.
I mean, we can talk about this in Q&A. I'm sure a lot of what's going to come up and a lot of still kind of uncharted territory is the role of how we control atrial fibrillation. Do we need to control atrial fibrillation? And the role of things like ablation. I think the short story is the jury's still out. I think there is a role when it's early and AFib is still starting, but we're still trying to figure that part out, which always comes as questions in a lot of these discussions with patients, and unfortunately still trying to understand that too.
Yeah, completely agree. So this is just a review that actually Stephanie Schwarting, one of the amyloid experts in Europe, put forth, just highlighting the 4 pillars of therapy that we use for all patients with heart failure. Those include beta blockers in the bottom, ACE inhibitors, something called mineralocorticoids, which is aldactone, spironolactone, alprazolam, finerenone, and then SGLT2 inhibitors, which are typically Farxiga or Jardiance. And the main message here is that amyloid patients are different than the general patient with heart failure. There are certain confounding factors, and that the 2 agents that most of us tend to prescribe are in green, SGLT2 inhibitors and MRAs. And there's some uncertainty about ACE inhibitors, ARBs, ARNIs, and beta blockers. And I'll quickly highlight at least some of the large studies that lead pause to the latter agents. So this is data from the National Amyloid Center in London, where they probably see the most amyloid patients of any center in the world. This is Julian Gilmore and Mariana Fontana and their work, in which they looked across these 3 agents, ACE inhibitors or ARBs. This is drugs called captopril, lisinopril, prinavil. They end in ill, but they're usually quite useful. Angiotensin receptor blockers, which are like losartan and valsartan or Diovan, Cozar. And those agents were not associated with any clinical benefit with regard to survival in patients who received them versus those who didn't. These are not randomized trials. These are what we call studies in which patients who took the drug were matched as best they could to a similar group of people who are not taking the drug, meaning same age, same type of amyloid. So we don't have compelling evidence that we should routinely prescribe ACE inhibitors or angiotensin receptor blockers. Beta blockers in all comers were not helpful, but interestingly, in the subgroup of patients who had an ejection fraction below 40% and were on a very low dose of a beta blocker called bisoprolol, the lowest dose is 2.5 milligrams, and everyone was receiving that dose, there was actually a clinical benefit toward the drugs with regard to survival in those whose hearts were not pumping well. This is, I think, somewhat controversial. It's led many of us to say, if you're taking a beta blocker at a low dose and you're tolerating it and you're in this group, I won't stop it. But many patients don't tolerate the beta blocker. And so I personally don't start a beta blocker for this group based on these data, because many patients in this group don't tolerate it. And the MRAs, which are aldactone, spironolactone, alprazolam that you may have been taking, they across the spectrum of ejection fraction, irrespective of whether the heart was pumping well or poorly, had a benefit in terms of survival, shown down in the purple. So I don't know, Nitasha, if you have things to add.
The only thing I would add, I really think, what I stress to patients in clinic is diuretics, which you don't obviously see here, right, are just a good Band-Aid, right? They keep the fluid off, they make you feel better, so they're certainly important, but no long-term benefit. So really try to use the SGLT2s like Jardiance, Farxiga, empagliflozin, dapagliflozin, right? And the MRAs, so spironolactone, eplerenone, now finerenone potentially, to try to keep the fluid off and use as much of those as we can and minimize the regular diuretics if possible, because we know those potentially have some long-term benefits, again, where the diuretics do not. So I try to kind of shift people as I meet them to those medications and on as minimal diuretics as they can be.
Yeah, we do the same. And I think what Tasha is talking about is diuretics, as she said, are being used to manage the fluid. But what we do know, at least from data from our center and others, is that the more loop diuretic, so furosemide, torsemide, bumetanide you take, the worse your prognosis. It's not meaning that the diuretics are actually harmful, but they're a biomarker, I think, of disease progression. And what we learned from other forms of heart disease is that these drugs, Jardiance, Farxiga, which are called sodium glucose cotransporter inhibitors, they tend to lessen the dose of the diuretic that you need to take and keep the fluid off. And there's evidence, as I'll show you in the next few slides, that they probably have clinical benefits in patients. So these are data from our center in which we started prescribing these agents. You can see there was a group of people who got the drug, shown in blue, and a group who did not. And here we're just looking at the dose of the Lasix that they were taking, or Lasix equivalent. And those who started the Jardiance or Farxiga, as Dr. Sarswat said, needed less diuretics, less loop diuretic. We were able to reduce the loop diuretic by about 25%. So say you are on, I don't know, 80 of Lasix, we would suggest you cut that dose to 60 when starting one of these agents because you need less diuretic. Interestingly, despite needing less diuretic, the weight went down further in these patients compared to the ones who didn't receive it. And notably, kidney function was pretty stable. There was an initial decline, but at the end of the period of follow-up. So preserving kidney function, needing less diuretics, but weight going down. So they seem to have a clinical benefit in removing water from the body. And again, the National Amyloid Center published this very important paper in the Journal of the American College of Cardiology, in which they found about 220 patients in their database who were treated with an SGLT2 inhibitor, and they matched them based on age and disease severity and everything to 220 patients who did not take an SGLT2 inhibitor. So again, not a randomized trial, but the best we have in this particular space. And you can see that there was, a slowing of the decline in the kidney function, attenuation in the rise in the NT-proBNP. They took less loop diuretics and they had good blood pressures. But more importantly, there was a reduction in these data in the chance of dying, both all cause and from a cardiac reason, about being in the hospital for heart failure, and overall, those hard endpoints were reduced. So these are agents that I think every patient should consider. There are reasons potentially not to take them, like you've had, serious and recurrent urinary tract infections because they make your urine change its composition to sugar, being very prevalent in the urine, and as a result, bacteria can, grow up there. So if you've had recurrent urinary tract infections, they may not be an ideal agent, but certainly the mainstay of therapy now. Nitasha, things to add? Nope, you said. Okay, I think that's it, Muriel. So we're happy to take any questions or how you want to run the next.
Well, like I said, we'll do some questions at the end, but I have a quick thing I want to throw in here because you mentioned, Dr. Maurer, that you had that study that you were doing where you were sending the biopsies to Mayo, and that 40% showed amyloid in the spine or wherever it was. That's a lot. So how long can we get away with saying that ATTR is a rare disease, do you think?
According to the FDA, until we prove that there are more than 200,000 people that actually are diagnosed and taking the drug. But I don't think it's a rare disease, to your point. But, the FDA has said that if it's rarely diagnosed, then it still meets their definition of a rare disease. The way we calculate it out, though, it's literally plausibly, in my mind, impossible for this to be a rare disease. I want to point out that not everyone who has, as Dr. Sarswat was saying, amyloid in their spine ends up with cardiac amyloid. That's part of what we're investigating. And I can tell you that, it's a minority of patients who, at this point, these are patients who had surgery within the last 20 years. So 7-8 years ago, a minority of them have developed cardiac involvement at this particular point in time. So while several of them may continue to develop, I also don't want people to be panicked about this. We tend to create a cohort of people who don't know much about amyloid because they feel well. They hear that they have it in a localized tissue, and then they go on the internet and they're worried they could have cardiac amyloid. The internet's got a lot of misinformation, and someone who's completely healthy, doesn't have any cardiac symptoms, is having a appropriate panic attack based on the misinformation I think they're giving. So my experience is majority of patients, 75-80%, do not develop it in their heart at least 7, 8, 10 years later. And who will and who won't is part of what we're all investigating. But we definitely believe that early identification of affected patients is the key to leveraging the therapies we have. The best thing you can do nowadays is find this disease as early as possible, because if you do that, in my experience, the current therapies are fantastic and basically prevent the disease from progressing.
Okay. And now we're going to hear from Paula about financial aid. And I hear there's some good news finally, Paula. So
Yes, there is some good news. First, I have just uploaded to the chat several of the links for the sites that I will be talking about. I have also put the link to our shared file folder that shows you the financial assistance chart that we have, that Bob will be pulling up here on the screen in a moment. But yeah, we've heard the doctors talking about these medicines, and now I'm going to tell you how to hopefully find assistance in paying for those medicines, because after all, that's the big thing, is they can prescribe it, but if we can't afford it, what good does it do us? But right now, currently, as of Friday, Friday afternoon, late Friday afternoon, there are now 4 organizations, and all 4 of them have open funds for amyloidosis. Healthwell Foundation, which is second on the list, actually has 2 separate funds for amyloidosis. They have their just straight amyloidosis fund. You do not have to be on Medicare to qualify for that fund, but they also have a cardiomyopathy fund. You do have to be on Medicare in order to qualify for that one. Medicaid may also apply to that. But that fund in particular, if you are on the drugs Eliquis, Farxiga, or Jardiance, those drugs have large copays that go along with them typically. All 3 of those drugs are covered under the cardiomyopathy fund. So say if you are on Amvuttra and are also taking, say Eliquis, you haven't had the big hit of the cost of tafamidis or Attruby or Wainua to your Part D Medicare, your drug policy. So you've got to meet that $2,100 out of pocket for this year. So this grant will help you to qualify for that. If you qualify for the grant, that will pay for your $2,100 that you're going to have to pay out of pocket for to get those drugs. They do cover pretty much all of the amyloid drugs under the cardiomyopathy grant as well. So don't think, well, I have to get the amyloidosis grant to cover this one, or this grant to cover this drug. No, you can get pretty much everything covered under the cardiomyopathy grant, as long as you have cardiomyopathy and that your income level is no higher than 500% of the federal poverty rate. Most of these organizations do use the 500% poverty rate level, which currently stands for a family of 2 at around $108,200 per year that you can make in income and still qualify for it. If you live in a large metropolitan area that has a higher cost of living and you're close to that threshold, please call the organization that you're looking at and ask them if there is an allowance because of the cost of living in your area. Sometimes they will allow you to make more per year. I don't know that amount. I've never seen it published, but you can request that. So know that is out there. Now, what has happened on July 1, the Patient Advocate Foundation and the Patient Access Network merged. So into one organization. And now it is all done under their totalassist.org website. This has made them the largest nonprofit that offers financial assistance to U.S. citizens. They have a lot of different funds. You know, if you have a disease, say you have rheumatoid arthritis along with this, you may be able to qualify for an arthritis fund through them as well as an amyloid fund. So don't just think just amyloid. Look at all of these foundations for help with any type of chronic disease that you have. They may have a fund out there for you. Some of these funds will pay for your copays, your co-insurance, deductibles, and sometimes they will also pay for your Part B or Part D premiums. Or if you're on private insurance, it can also cover your private insurance premiums. So keep that in mind. This is not always just for medications. There is help out there for travel assistance. The Patient Advocate Foundation has a specified travel fund. If you're looking down their list of diseases, you go to travel. So just look for travel on the list and you can see if you possibly qualify for that grant as well. The assistance fund, you will have to call them to find out about qualifying for them. They would not give me that information over the phone when I contacted them a couple years ago. They were not comfortable giving it out. I don't know why, but I have no idea how much their grants will allow or, you know, what the percentage rate is that you have to fall under to qualify for them. Just know this help is out there. And we very rarely, if ever, see all 4 or 5 of these funds open at one time. They could all be closed by Monday. So don't sit around and wait, say, oh, well, I'll apply next week. You apply Monday morning at 8 a.m. Do it as quickly as possible because these funds do close without warning. And they do reopen several times throughout the year. Most of them do. They have email wait lists that you can sign up for. I highly recommend that you do that because then once that fund reopens, they will send you an email that says we are now accepting applications for these specific funds. And if your fund is on there, then you can go back and apply for a new grant if your grant has run out. They do not always line up for when your grant runs out. I have one for arthritis with the Patient Advocate Foundation that ran out in May. It didn't open back up until June. So I did have it ran out in April. I had a couple month period where I was not covered by any grant, but I reapplied when it reopened because I got that email. You can apply over the phone or you can apply online with most all of these organizations. So just know that it's out there. Take advantage of these funds. If you're not sure if you qualify, call them and talk to them. They'll be happy to help you. But there is money out there, folks. Take advantage of it. And
Thank you. Thank you. And if you have any questions, there's always Paula at amyloidosissupport.org.
correct.
She loves taking emails and answering questions. She's unlike me, she's the nice one in the group. Okay.
Oh, yeah.
Between Paula and Monica, we've got it made, guys. We're very lucky.
And I learned what I know from Monica. So take her webinars. They are excellent. I highly recommend them. Sign up for that October 1st webinar. You won't regret it.
Absolutely. And now we're going to hear about neuropathy from Dr. Karam. And I do want to, and for our wild type people, I know you're frustrated because people keep telling you wild type are not known for neuropathy, but we all know, and Dr. Karam knows, that wild type people also have neuropathy. So Dr. Karam, take it away.
Thank you, Muriel. So we're going to focus on polyneuropathy. We're going to talk first about the current and potential future treatment that are currently being studied for hATTR neuropathy. Then we're going to talk a little bit about discussing the management of the sensory symptoms. And then we will end with discussion of the management of dysautonomia, which is has major impact on the quality of life, as you guys know. So first, let's identify what are the neurological ATTR symptoms. You have a bunch of them. There's the peripheral neuropathy. That's the classic length dependent, usually, meaning that the feet, the toes, the feet are affected first. People start having symptoms in the feet. The second one is the spinal stenosis, where there's tightening of the nerve exiting the spine at the back level, usually at the lower back, but can also happen at the cervical spine, meaning at the neck. And then you have the entrapment neuropathy, where the nerve itself is normal and not affected by the disease, but the connective tissue around it is pressing on the nerve and causing symptoms. And the classical example for this is carpal tunnel syndrome. Symptoms of neuropathy and spinal stenosis and entrapment neuropathy can be sometimes difficult to differentiate. Your neurologist can help you differentiate. They may ask for nerve conduction studies, electromyography, imaging of the spine and nerves with MRI or ultrasound to determine where the problem is coming from. These symptoms include pain, stabbing, shocking, burning sensation, numbness, like a dead asleep feeling that is persistent, tingling, and then weakness that can be exemplified by difficulty opening jars, difficulty climbing stairs, getting up from a chair, fatigue, loss of balance, tripping over your feet, dexterity issues, and muscle atrophy. Another manifestation of neurological ATTR is the autonomic neuropathy. So these are the nerve going to your guts, to your lungs, to your heart, to your blood vessels, to your eyes, to your sweat glands, and unfortunately you cannot control those. So these are controlled by your autonomic nervous system, which many times can be involved in amyloidosis. And some of these symptoms include orthostatism, meaning you stand up, your blood pressure drop, and you feel lightheaded or pain in your neck. Your vision may dim, and if it's severe enough, you may pass out. Nausea and vomiting because of GI dysfunction, diarrhea, constipation, and sometimes alternating diarrhea and constipation. Sweating issue, meaning that you're not sweating enough, and that can result in overheating and heat intolerance. Sometimes people think they're sweating too much, and that's because certain areas of their body are trying to compensate, and they're actually not sweating enough. Just the upper body, for example, is sweating too much. Erectile dysfunction is a common problem in men, can happen many years before the diagnosis is made, and then visual issues, urinary issues, and weight loss. And then we spoke a lot about the TTR production. It's mainly by the liver, but know that the brain and the eye both make TTR as well. And unfortunately, the current therapy that we have do not target the TTR that is being made at the level of the brain or the eyes. People can have memory issues, headache, imbalance, seizures, weakness, and stroke-like episode if the brain is involved. They can also have eye issues with floaters, opacificating the vision. They cannot see very well, and glaucoma, and so forth. So the way we manage neurological symptoms of ATTR, we're going to target the symptoms and we're going to target the ATTR. We've heard a lot about targeting the ATTR, and there's overlap between these treatments. At the end of the day, amyloid is the same disease, ATTR, so whether you target the heart or the nerve, in theory, they should be both helpful. So we'll first start very briefly talking about targeting the ATTR. There's currently 3 drugs in the United States approved for ATTR polyneuropathy that is caused by a gene variant. So these are not for wild-type TTR. Patisiran, vutrisiran, and eplontersen. Vutrisiran is approved for both the ATTR cardiomyopathy and the hereditary ATTR polyneuropathy. Eplontersen and patisiran are approved for the hereditary ATTR polyneuropathy. The major difference between vutrisiran and eplontersen is one, you give it injection via a healthcare provider once every 3 months. That's for the vutrisiran. Eplontersen is given by the patient themselves or their caregiver once a month. So the drug is typically shipped to your home. Patisiran is an IV drug. We are using it very rarely these days because it's once every 3 weeks. You have to pre-medicate. But overall, we suspect that the efficacy for these 3 drugs is similar, and what people choose is depending on their preference rather than efficacy-wise. Then targeting the symptoms is going to be very important with the pain and discomfort, which can affect significantly quality of life, similar for dysautonomia. So we talked about patisiran. It's an IV drug that was the earlier silencer, if you want, of the TTR made by the liver. Now we have 2 newer drugs, vutrisiran, which is also called Amvuttra, or eplontersen, which is also called Wainua. They both basically do the same thing, which is suppressing the liver production of the transthyretin or TTR protein. They tell the liver to stop making it, and if you measure in the blood, the levels drop quickly with both medication to reach maybe about 20% of what they're supposed to be. And you can measure that, by the way, in the blood. So if you measure the pre-albumin, this is what is still called in the old lab. This is exactly what the TTR is, and you can measure it before and after starting treatment, and you can see that it typically drops significantly. Sometimes actually a lot of time we cannot measure it anymore. This is how effective these drugs are. And if you look at the neuropathy impairment score, which is your neurological examination, meaning when the physician is examining how strong you are, the reflexes, your sensation, plus a few other measurements like the nerve conduction study and heart rate, deep breathing, and so forth, you see that people who are on the drug, vutrisiran and eplontersen, are relatively stable. And I do agree with Dr. Maurer, who was mentioning that if you start these drugs early enough, you can really halt the progression of the disease. Moreover, you can actually reverse some of the symptoms of neuropathy, and I've seen that in many of the patients that were treated early on. If you start the treatment late, unfortunately, a lot of time, the most we can hope is to make people stable. This is the pink line here and the blue line here. This is the placebo, and you can see how rapidly progressive this neuropathy is if untreated. Similar findings are for the Norfolk quality of life, and this asks you about your pain level and autonomic symptoms, etc. And you can see that things are stable, and sometimes they improve a little bit with these drugs compared to the placebo. The good news is that the effectiveness of these drugs seems to be long-lasting. So if you follow patient up to 5 years in this study done on patisiran, you can see that many people really are relatively stable, maybe very slow progression. And if you were not treating these patients, a lot of time, unfortunately, the results are terrible for the patient. One thing that I'm going to point out again is that this is the placebo arm that switched later to drug, and you can see what is lost, unfortunately, is lost, and they can never rejoin people who started treatment early. And this is why we stress again about early diagnosis and early treatment. How about the future? So there are still ongoing clinical trial in polyneuropathy. There's the Triton, which is the nucresiran. So this is a newer version of the patisiran and vutrisiran. It's an RNA interfering drug. It's injected every 6 months instead of the vutrisiran every 3 months and patisiran every 3 weeks. And then there's the gene therapy, CRISPR, with nexiguran, and this is ongoing, but not in the United States because it is being compared to placebo, which is probably unethical because we have drugs these days. And then finally, we have prevention of polyneuropathy. So these are children of people who have amyloid and they carry the gene, and they have to meet certain criteria, like being within 10 years of when the parents start having symptoms. And you can be enrolled into this trial to see if acoramidis, which is one of the stabilizer that Dr. Maurer mentioned earlier, can prevent the onset of disease. And this is really something that we're looking forward to in the future, probably several years from now, for us to know the results. Pain is a major issue in amyloidosis, and the treatment doesn't necessarily always help with the pain, meaning that if you start the silencer or even the stabilizer, it doesn't necessarily mean that the pain is going to go away. And the reason is once the nerves are damaged, they can keep acting up. And it's hard to predict, and we don't really have very good medication for those. Most of these medications that we are prescribing are off-label, meaning that they have not been studied for amyloid neuropathy specifically. And certain symptoms like the lack of sensation, the numbness, the sleep feeling, do not really improve with the pain. So some patients don't have pain, they just have this uncomfortable loss of sensation or numbness feeling. And for that, unfortunately, we don't have any medication. So what are these drugs that we're talking about? They fall into two main categories. There are anti-seizure drugs and they are antidepressants. So these are the two main categories of medication that we can try. And unfortunately, a lot of time is trial and error, meaning we can try a medication, go up on the dose if the patient is able to tolerate, and see if they can benefit the patient. And a lot of time we have to use combination therapy, meaning we use an anti-seizure and antidepressant. There's obviously other options like topical ointment or cream with lidocaine or capsaicin, opiates when the pain is really severe. Unfortunately, long studies with opiates and neuropathy have shown that long-term it's not really a very good option. So maybe something short-term. All of these medication, I tell my patient, it's really you have to see the benefits and risks and really how much you can tolerate, because most of them will give side effects. And you have to be very careful, because if you have dysautonomia, some of these side effects can make the dysautonomia worse, or the constipation and so forth. Alternative treatment is rarely discussed because it's not a pill that you can prescribe, but believe it or not, a lot of these can help the patient. Exercise, for example, has been shown to reduce the pain and improve strength in certain situations. So I always recommend exercising. Obviously, if the patient has heart failure, there's some limitation, but gentle exercise will always be good. Some people report benefit with alpha lipoic acid. It's not really clear if it works. It's a supplement that you buy over the counter. Obviously, listening to your body. Some people feel tight socks help. Some other feel like wool socks help. So you have to try different things and see what helps. Meditation and so forth. The dysautonomia is a major problem. This is the symptoms of dysautonomia. They include orthostatic hypotension, erectile dysfunction, heat intolerance, gastrointestinal problems, and incontinence. We talked about those a little bit more before, but basically what happens, especially with orthostatic hypotension, which can be serious because it can lead to falls, breaking your hip or your wrist, and if you pass out on the stairs, then it could be catastrophic. But basically what happens is that normally your blood pressure is regulated by these nerves going to your blood vessels and to your heart. And when you stand up, gravity will do its work and try to reduce your blood pressure, but your nervous system will react to cause the pressure to remain stable. Unfortunately, in people with amyloidosis, this baroreflex is not working very well. And what ends up happening is when you stand up, the blood pressure will drop. And when it drops below 80 millimeter of mercury for the systolic, you may have symptoms, which include loss of consciousness, if severe enough. So we have ways to overcome this. They're not great, but I think education and for the patient to understand what's going on is extremely important. Another thing is that your body will try to compensate by causing what we call supine hypertension, meaning that when you sit or lay down, your blood pressure may shoot up. And if you treat that, it's going to cause more problems. So Salt your food if the cardiologist allows it. Drink water. If you have a lot of symptoms, you can drink 2 cups of water quickly, and that will raise your blood pressure. Increase the head of the bed by 30 to 45 degrees. That can help as well. Exercise again with recumbent exercise if you cannot tolerate exercising standing up. An abdominal binder to shift the blood from your guts to your brain. If those don't work, we can try midodrine, droxidopa, and other medication as well. And Muriel, just interrupt me if I'm taking too long. GI issues, we have many different ways to overcome the constipation or the diarrhea or the gastroparesis. And then we have medication for incontinence. These symptoms should be discussed with your doctors, medication for erectile dysfunction. And then for the other problems, such as the hand weakness, you can try occupational therapy, try different exercise. For the stenosis and radiculopathy, you can try physical therapy and, if needed, surgery. For the foot brace, if the balance is affected and you're falling, you're going to have to use a walker. So a lot of my patients are embarrassed by the walker, but I tell them, if you fall and break your hip, I would rather be embarrassed than breaking my hip, because it's a big problem. Carpal tunnel syndrome, there's surgical evaluation, wrist splints if it's mild. One of the things that has been mentioned many times, and I'd like to comment on this, is yes, we do find amyloid everywhere in the body, and many times, especially in wild type, it can manifest several years, and I would argue even decades before the disease affects the heart. So from one way, I don't think we should alarm people by overdiagnosing wild type amyloid elsewhere, unless it's really affecting the heart. Ocular and CNS are hard to manage. We have some off-label treatment, but they're really experimental and should be evaluated on a case by case. So I will stop here. Thank you very much.
Thank you. Well, I'm sure we'll have lots of questions in a bit. Before we get to the Q&A, I know our Bob Gibson is going to give us a quick registry update. So, Bob, take it away.
Thank you, Muriel. Let me bring up a few slides as we talk about this, and I'll be brief with this. This is something that Muriel is exceedingly excited about, as you can tell by her expression if she's still on the screen. But we have been at work developing a voice of the patient amyloidosis patient registry for some time now. So I'm going to quickly take you through what we're doing and tell you a little bit about what will happen when we launch. We are planning on launching this in October. And in fact, we just got through with patient testing. Some of you on the call may have actually contributed to that. And we're incorporating all of those suggestions that you made and the feedback that you gave to make sure that this is something that's going to work well for our patients. So what the registry is, if you think about it, it's really just a series of surveys that we will ask patients to fill out that will be contained online in the cloud. And our partner in this is the National Organization of Rare Disorders, NORD. They have a platform called I Am Rare that's hosting 50 plus patient registries right now and other disease types. This is what we call a natural history registry, where we'll be taking data from patients. We'll be gathering, as you can see here, after patients sign up, and you have to register and you have to give your consent. But then you will be able to fill out a series of surveys. The pathway usually is we'll get your basic demographic information. Then we'll ask you about your amyloidosis diagnosis. We'll go over symptoms that you have had. We'll ask about your current health and well-being. And then we will get information on the treatments that you are receiving and measure quality of life. And the presentations that you've seen from our doctors on the panel today, you've seen things like the KCCQ and the Norfolk Quality of Life scoring. Those are quality of life measures. We actually have a few others that we're using within the context of the registry that are specifically targeted to TTR amyloidosis. Also, I should mention that this is open to anyone with amyloidosis in the United States. not just TTR. There are other forms, although we will focus here on the TTR. We're very focused on the privacy aspects of this and the security of the information, and we have a lot of confidence that the Nord IAM-RARE platform that we are using is strong in both of those areas. So what will happen is after we gather enough information from patients, this will become a research resource for the amyloidosis community. We will have researchers who will gain access to the registry once they have an approved study, and that we approve them in two steps. One, they have to have an IRB approval process, and then our board members will have to approve the use of that study in the registry. But then they can get access to anonymized data within the registry that contains all of your inputs. And they can do that for a variety of reasons. They can contact patients within the registry through a firewall that we set up, so they won't know your names, but they will know some information about you for the type of amyloidosis you have, or maybe it's the treatments that you're on, or the symptoms, or some combination thereof. And then they will contact you to ask whether or not you would participate in their research projects. This could also be used for participation for clinical trials as well. And then over time, we will ask you to update that information. Could be every 6 months, it could be annually. It really depends on the schedule that you will determine once you join the registry. What this really means to us, it's an amplification of the patient voice. It's a way to get information about how we live with amyloidosis, and more of us are living with amyloidosis, given the treatments and the great quality of the physicians that are treating us. So we like to say, as you know, for ASG, it's our tagline, you are not alone. So one voice, one patient set of data can be useful for that individual patient. But what we're trying to do is create a whole course out of this. So the more that we get in this, the more together we become, and the amplification that it can create for the patient voice can be very, very significant. When we do launch this, we're targeting October. We're getting the information back from the patients from the testing, and we're applying that right now. And that's one of the final steps before we get to our launch date. But once we launch it, we would want you to sign up and add your data. We'll be reaching out to centers of excellence and physicians who treat amyloidosis to inform them about what we're doing and get them to introduce that to their patients and encourage them to join. And then the supporting organizations, our sister amyloidosis advocacy groups like the Research Consortium, the Foundation, and others, we'll be asking them as well to spread the word for this. So please keep your eyes peeled for more information coming from us in October. And when you get it, please sign up and add your voice to this. Thanks. That's it.
Thank you so much. This is very exciting. We've waited a long time, so we're really excited about this. Thank you, Bob. Okay, now we're going to get to some questions, okay? So if I can have all of our doctors, you're now considered our panel. Okay. Now, Josie is very interested in the study that Dr. Cuddy's doing in reference to the exercise. Is it for polyneuropathy or just cardiomyopathy?
It's a great question. I apologize. I don't know the definitive answer, but you can reach out to Dr. Cuddy or I can connect you with her. I think it's mainly for cardiomyopathy patients, but I think patients who have a mixed phenotype are eligible, but she would know the details.
Okay. And Josie also wants to know how she can find out more about the study being done by Goyle in reference to the beta blockers. Josie takes a low-dose beta blocker for essential tremor unrelated to amyloidosis and wonders if it causes drug interaction with her Onpattro infusions.
Yeah, well, the trial that Dr. Goyle is doing is one in which people on beta blockers are weaned off their beta blockers, and the primary comparison is what is their exercise capacity. Again, these are being conducted in the particular cities that they're, so you probably need to be in close proximity unless you can travel, but I can connect anyone to any of those investigators. I believe both of their trials, by the way, or programs are listed on clinicaltrials.gov. So you can also find them there in their contact information.
Okay, Dr. Karam, here's one that'll put you on the spot. Okay, is Amvuttra the only and best treatment for hereditary type PN?
It's the only treatment. No, there's 3 currently approved in the US. There's Wainua or eplontersen, there's Onpattro or patisiran, and there's vutrisiran or Amvuttra. Which one is better? We don't know because they were not studied head to head. So they were not, the way they were studied was against placebo or historical placebo. So we don't know if one is superior to the other.
Okay, measuring prealbumin, okay, or measuring TTR in the blood. This comes up a lot in our Facebook group because I know when you take the stabilizer, the numbers go one direction, and then when you take the silencers, they go in the other direction. So George must know, is an extremely low level of prealbumin in a blood test good or bad? Is prealbumin reduced by taking an amyloid drug?
Yeah, so that's why we differentiate between silencers and stabilizers. So the silencers are reducing the TTR protein, which is also called prealbumin, when you do the lab test, and that's exactly what the purpose is. So if you're taking a silencer, your TTR level should drop, and if you're taking a stabilizer, this is going to stabilize the protein, so it would keep it the same or maybe increase it actually. Now, if you're taking both drugs, which I personally do not recommend, you would not really know, because if you still have, now some patients have completely suppressed when you take both, and some patients have low levels, and I don't know if that is caused by the combination or they're just not responding as well to the drug. So it gets confusing when people are on both.
That's interesting. I saw Dr. Maurer give a little grin when you said you personally didn't recommend both. So, Dr. Maurer, you grinned. Did you know that?
Yeah, I agree with Chafic. Despite us desiring that 2 drugs would be better than one, there's actually little to no evidence of that, and there'll be data forthcoming that we'll present at ESC, but the top line results were a large trial in which combination therapy was used in a vast majority of the patients. And the trial was neutral, and what we learned was that monotherapy, the drug was effective. So we have 3 or 4 effective drugs, but the idea of combining them is something we're all interested in, but at least on average, the data is not supportive of that idea. Taking more is not always necessarily better. I would comment also that this whole issue of how much your TTR levels go down or up with a stabilizer or silencer is very, very, very complicated, and will only become more complicated as we see more and more patients, at least in trials, taking combination treatment. As best we can tell, there's at least 8 different ways to determine whether a silencer is knocking down the protein and how to measure it. And those include mean or median values, transforming the values or using the absolute, meaning log transform, because the data is not normally distributed. These are mathematical things. And then whether you compare patients to where they started from or to the placebo group, who might be more often, for example, taking a stabilizer, because if they were on a placebo at the beginning and they start, say, tafamidis or acoramidis, their TTR levels are going to go up. And so, again, I think we have a lot more to learn. Never mind that, at the end of treatment, when you use a silencer, we don't know how much of the protein left over is really amyloidogenic or not. We're just measuring absolute concentrations. So I just urge patients out there, there is, my experience is going to be a lot of people telling you one drug might be better than another with regard to certain factors, but I think the proof is yet to be determined. The good news is we have 3 or 4, if you want to count all 4 of them, very effective agents, and the only mistake is not to take one of them, right? That is the wrong decision. You have this disease, you should take a drug that treats the disease. But the idea that one agent is far superior to another, which I know is what every patient asks me, I completely agree. We don't have any data to suggest that. I know that's very unsatisfying to people, but that's the realities and that's the truth. And our job as clinicians is not to tell you things that are untrue, but to tell you the facts so you can make a best decision you could.
Dr. Sarswat, let's hear your 2 cents here.
And now I agree. I think, again, like we mentioned this, I can't, tell you that there's any benefit to combination therapy or that one is better than another. And really, it comes down to a discussion with who you're comfortable with, right? Which I think, especially from the cardiomyopathy standpoint, between silencer versus stabilizer, some of it depends. Do you have autonomic neuropathy? Do you have polyneuropathy? That might push us more towards a silencer. Some of it is just mechanism of drug action. There are certain people that say, I don't want to take any more pills. I only want the injection, and vice versa. So some of it is just a discussion with your clinician and who you're comfortable with to help make those decisions and what's best for you and family too.
Yeah, the ASG is asked that question all the time, and we see it discussed. And our response is, as long as insurance lets you get away with both, we're all for it. So just so you know, we don't know how long that will last, but it is what it is. Okay. Oh, I do want to say we're having a storm here in Chicago, so if I lose power, someone else will take over. Okay, just so you know. Okay. Okay, and here's another question: is the gold standard treatment stabilizer or silencer? We kind of answered that, I guess. So we'll go to another one. Where can I get more? Where can I get more information on the effect of exercise on amyloidosis cardiomyopathy? I know Dr. Maurer brought up exercise, but since we have you on the screen, Dr. Sarswat.
Yeah, I think we don't have great data. I think I would say, we extrapolate the data from heart failure in general, and the short answer is exercise is wonderful, right? Do as much as you can. I think a lot of patients ask me, at what heart rate should I stop? Where's my limit? That I can't tell you. I think some of that right now, until we have good data, is common sense. You start feeling uncomfortable, you start feeling dizzy on the treadmill, stop. But in general, exercise is good for your heart. It's good for you overall. Even if the heart's not pushing out the right amount of blood flow to all your tissues, exercise helps your other tissues be more efficient at extracting whatever oxygen and nutrients it gets and is helpful.
Okay. Okay. Please speak to ejection fraction reduced and preferred sudden drop with wild type. Okay, that's what Ben asked. So now I know that we're known as heart failure with preserved ejection fraction for the most part. A sudden drop with wild type, would that be due to orthostatic hypotension?
Not typically, no. So just to reiterate, ejection fraction is a measure in which the numerator is the amount of blood that the heart pumps every beat, which is called the stroke volume. So a normal heart pumps, say, 70 milliliters of blood every beat, and a normal heart might hold somewhere around 100 milliliters of blood. So when it's done pumping, it went from 100 down to 30. Therefore, the difference between 100 and 30 is 70. You take the 70, which is the stroke volume, and divide it by the 100, that's how you get the ejection fraction. The problem in amyloid heart disease is the numerator and denominator can both go down together because the heart may not be able to fill very well. Therefore, in an extreme example, the heart might only fill to 50 milliliters of blood, but it might go down to as little as 15 milliliters of blood. So therefore, it is pumping 35. And if you divide 35 by 50, you still get 70%. So ejection fraction has always been a very poor measure of how the heart works in patients who have amyloid heart disease. Other measures are utilized. Sometimes people talk about strain. We have talked for years about something called the myocardial contraction fraction, which is analogous to strain. That's a measure of the stroke volume divided by the myocardial volume. The main thing to note first off is EF is not the measurement that you should, I think, hold your hat on. You can feel wonderful and have a normal EF. You can feel pretty terrible and have a normal EF. And so it doesn't really explain symptoms. Ejection fraction does decline usually over time, albeit slowly. If there's a precipitous decline in the ejection fraction from, in the last few months, say, usually in my experience, we'll see what my colleagues have, patients develop some intercurrent event like an atrial arrhythmia. So they go from normal sinus rhythm into atrial fibrillation. That could really lead. Or patients can have more problems than just amyloid heart disease. Many of our patients are older adults, and they can have concomitant valve lesions or coronary artery disease. And so it requires the cardiologist to ask, this is a little unusual. Amyloid, the ejection fraction might go down a few points every 6 months or year, but a marked precipitous decline requires someone to ask the question, why is that happening and what can I do about it? Because it's unusual. See what my colleagues think.
Any other comments? No?
No, I mean, I completely agree. I feel like even if there is progression of amyloid, it's not going to cause a sudden drop in ejection fraction. We're looking for other reasons, generally coronary artery disease being a common one. Did something happen there? Exactly what Matt said. I feel like lots of times patients will go into a sudden arrhythmia and somebody gets an echo in that situation and the ejection fraction looks worse and everybody gets nervous. And often it comes right back up when we're out of the arrhythmia too.
Okay. Is cubital tunnel syndrome also a manifestation? Dr. Sarswat.
I would assume yes. I would assume that any of those types of things that can affect the hand are manifestations of amyloid. I mean, we can see what Dr. Karam says as well, but I feel like amyloid loves the hand, and every time we go looking for it from any of these issues, it ends up being amyloid deposition.
Okay. I do want to say that we're only going to be answering the general questions. Anything that is kind of personal, what I'll do is I'll give those to the doctors and see if they can give you a response, and we'll get those to you later. Okay.
Muriel, can I just make one comment more about ejection fraction and all
Oh,
of
absolutely.
all of these measurements? So, the assumption here is that your echo is being done and being interpreted by, in my opinion, the same person or some artificial intelligence, something over time. You should be all aware that there is marked variance in how two doctors would, on the same day, on the same echo, read your, for example, ejection fraction. This has been studied. So, if they put one cardiologist in a room, ask them what the ejection fraction is, and ask the next cardiologist what it is, the variance in the absolute measurement is plus or minus 7%, which means if yours is 45, the next doctor reading the same echo and the same could say it's as high as 52 or as low as, 38 or something like that. So often these measurements, when they're read and there's a big change, need to first and foremost, someone needs to ask, is that really true? Is there really a difference between the two where someone takes a look at both of them and the same person side by side to check? For example, in the studies we've done about measuring the wall thickness over years with an S changes a millimeter or two. If someone tells you in 6 months that your wall thickness went from 12 to 18 millimeters, that is biologically implausible. It doesn't get that thick that quickly in amyloid. And what it usually means is, so you're trying to measure the wall thickness, you're supposed to be completely perpendicular to the wall. But if you're off axis and you measure it in the wrong way, because the heart is three-dimensional, you will get a much bigger or longer wall thickness, wider, because you're just not measuring it correctly. So I'd urge everybody to go into the thought that imaging rarely changes in 6 months or a year, in my experience. And if there are dramatic changes, the first thing to do is not to panic that there's been a demonstrable change, but to ask the doctors, is this really real? If it is, then all the other investigations we talked about, but often it creates more anxiety than it's worth.
You brought up imaging, which triggered something in my brain. Okay, we don't hear much now about the imaging trials, the Atralis trials, the University of Tennessee imaging. Why is that, and what's happened? What's the latest on that?
You'll hear quite a bit more. The REVEAL trial, which is the trial that used Jonathan Wall's compound to identify people with cardiac amyloid and serve as a diagnostic test is completed. And the paper will be presented high level by Dr. Darbola at the European Society of Cardiology. And there's hopeful a simultaneous publication. All I can tell you is there are a lot of advances in imaging. And the PET scanning agent is, I think, one of the big advances and could be utilized not only to diagnose people, but also potentially to track amyloid potentially over time. That's not what the original trial was about. The original trial was a diagnostic trial, not one to track, but has a lot of hope. These are not yet approved agents. So you can't get this at your local doctor's office. The FDA and the EMA have to read the data and agree that they want this on the market. But I hope they agree, because I think it would be a big advance and could be something that we will image patients with at some set periods of time.
Yeah, that'll be great. We can monitor patients in theory, right? By watching, seeing if the amyloid shrinks in their various organs. That's what patients are waiting for. They want to hear that, they want to see that they're getting better, not just hear it from their doctors or because they feel better. They want to see it. They want some kind of biomarker they can check. So this is exciting. Yes. Okay. What I don't understand this question, Dr. Maurer. When will a cleaner medicine be approved through a trial? What does that mean?
I don't know. So you have to ask the person who asked it. I don't know.
Does anyone understand that one?
Most of
Are
the
they
drugs
asking
we
about
have,
depleters,
Players,
perhaps?
yeah.
I don't know what they're asking about.
maybe clearer. Maybe they make a drug to clear amyloid. That would make sense.
Oh,
Yeah,
okay.
depleter.
Yeah.
Okay, maybe
just
they
a
just
typo. Yeah,
Yeah,
I don't know the answer. The most advanced agent is Clearamitug, which is a fully enrolled trial of over 1,100 people. They've actually been dosed for on average over a year. It's a randomized trial, and we still expect that it will take another 2 years of the trial to determine whether a drug worked or not. If it works, then hopefully they'll move quickly to get regulatory approval. But we all agree these things take way longer than we all want, for sure.
Okay. Pain from spinal stenosis, carpal tunnel, foot neuropathy can be significant. What medication is typically prescribed to manage pain? So we'll throw this to Dr. Karam. Can low dosage of hydrocodone help in controlling pain?
Yeah, so these are 3 different problems, the spinal stenosis, carpal tunnel, and neuropathy, right? This is the 3 issues. Some of the pain medication that we can prescribe can help with all of them. So gabapentin or amitriptyline, for example, can help with. But at the end of the day, you need targeted therapy as well. So carpal tunnel syndrome, if it's surgically amenable, which a lot of time it is, that we recommend this to do the surgery. It's an outpatient surgery and with local anesthesia. And spinal stenosis, same thing. If it's severe enough to cause weakness or pain that does not get better, then surgery may be an option. Other people may benefit from local injection to the back with steroid and lidocaine. But at the end of the day, physical therapy can be very helpful in people with chronic back pain. And then for the neuropathy, I mentioned several medications that we can try. But at the end of the day, it's really trial and error and see what helps the most without causing a lot of side effects, because a lot of these medications can cause side effects. If nothing works and you need opiates, that is fine. But know that these drugs can cause also side effects, and there's people get used to them and they end up needing higher and higher dose. So long term, a lot of time the opiates are not recommended. It's a good short term, but for long term, there may be new medication in the future that we can use, hopefully. By the way, different mechanisms of action. So some of them seems to be very promising, and hopefully they will be approved in the near future, so we can use them as well.
Thank you. Dr. Sarswat, here's one for you. Back in the day, before all these treatments, doxycycline was a hot drug for people to take. There were doxycycline trials. They thought maybe it might act like a depleter. Is there any value to taking doxycycline anymore? Any advantage? Mark wants to know, is there an advantage to taking the drug doxycycline HYC 100 milligrams for amyloidosis?
I would say nothing is really, unfortunately, borne out as being clearly beneficial with doxycycline. And now we have wonderful proven drugs. So, I mean, I myself used to prescribe doxycycline back in the day, but certainly not in the last 5 years, at least I would say, because we have drugs that we know are clearly beneficial. So really that role has fallen apart.
Okay, Dr. Maurer, what about you and doxycycline?
Yeah, I don't prescribe it either. And just warning, it has certain side effects. People can get quite a bit of GI upset with doxycycline. Rodney Falk years ago was doing a trial of Tutka and doxycycline, and we saw that. And there's a sun sensitivity. So I would avoid taking it on the idea that you're taking it specifically for treating amyloid.
Okay, well, Dr. Maurer, what was the name of the beta blocker that was effective and safe at low doses?
Yeah, the name of the one that they use in Europe is called bisoprolol. I think the main message, I don't think there's any definitive evidence that that's the one you have to prescribe. I was just trying to emphasize that beta blockers, if they're to be utilized in amyloid, should be probably always utilized at a very low dose. So if someone's on a very high dose of a beta blocker, they often can have very slow heart rates. And in the example I was giving you about the ejection fraction, where both cases had normal ejection fractions of 70%, but one heart was pumping 70 milliliters and one heart was only pumping 35. In amyloid, a faster heart rate is often necessary to maintain the amount of blood that's circulating, which is called the cardiac output. So paradoxically, doctors sometimes think, oh, the heart rate's 100 or 90, I'm going to slow it down. They give increasing doses of beta blockers to slow down the heart rate. That doesn't improve the heart's performance. And in reality, because the heart rate's so much lower, the patient could feel more fatigued or tired. So these are very individualized discussions, but I would say if you're on a high dose beta blocker, revisit your local doctor and ask, do I really need to be on this dose of the beta blocker? Again, I don't think there's specific evidence that one is better than another, but the one that was utilized in Europe, which is available in the US, is called bisoprolol.
Spell that.
bisoprolol, bisoprolol.
Gotcha. Well, that answers Michael's question here. Michael had asked, I've been prescribed a beta blocker. Should I be having a conversation about whether to continue it? So I guess the answer to Michael is he should talk to his doctor about that.
Yeah, I think so.
Okay, let's see. Okay, Dr. Karam, you kind of answered this, but what is the best treatment currently for musculoskeletal autonomic PN type?
So the musculoskeletal really depends what you mean. Is it joint? Is it back, etc.? Again, the treatment is still exactly what have done in people without amyloidosis. So there's no reason to treat it in a different way. And unfortunately, the current drug that we have are not going to reverse the problem once it happens. So that's number one. And then for the autonomic dysfunction, it really depends on the symptoms. Again, is it the GI issue? Is it the orthostatic hypotension, meaning the lightheadedness when going from a laying down or sitting position to standing up? Is it the erectile dysfunction? So depending specifically on each symptoms, they can address those as well. So again, the treatment for amyloidosis is post-treatment the root cause, which is the amyloid, and trying to either silence the liver from making it or stabilize the circulating TTR, and then management of the symptoms. And management of the symptoms most of the time really follows the classic way we manage any symptoms like back pain or knee issues and so forth.
Okay. Okay, depleter. All right, I don't know if we don't have much data on the depleter drug trials, do we, Dr. Maurer?
We have data that was recently published from the phase 1 depleter trial of the drug clearamitug that was dosed in a very small cohort of patients, not more than 40. And this was long-term data that intriguingly showed, was published in, I believe, Nature Medicine. Dr. Pablo Garcia Pavia was one of the seminal authors, but it did show that the echoes in those patients, their cardiac structure and function was improving over time. It also, I think some of the data raises the possibility that we're not sure, but with depleters, you may not need to be on long-term rest of your life therapy, right? You could remove potentially, if it works, enough amyloid from the heart in a year or 18 months or maybe 2 years. Some patients who have more may need longer therapy. Some who are better responsive may need less. And then ultimately, once you've gotten rid of most of the amyloid, you would then stay on, as Dr. Karam was saying, a therapy to prevent amyloid from coming back into the heart, like a stabilizer or a silencer. But these are phase 2 studies with very small numbers of patients. And the bottom line is we have to prove that the drugs work in larger trials before they'll become available. I personally still have a lot of hope for them.
Okay. Let's see. So when Carol just had a pump put in, and this will make this for Dr. Sarswat. She's worsening, holding fluid, gaining weight, can't breathe, taking 200 milligrams of torsemide. Are you aware what kind of pump that would be, Dr. Sarswat?
I'm assuming maybe you mean an LVAD as a pump, which is a pretty rare thing that we do for amyloid, just because the cavity, the space in the heart where the blood fills is pretty small, and it usually doesn't actually fit well, but I can't think of what other type of pump she's talking about. That we usually do kind of more for end-stage heart failure. And it sounds like she's on pretty high doses of diuretics. And I would really, I don't know if she's a candidate for transplant or any of those types of things, but heart transplant is a good option if she's able to.
Okay. Can someone with chronic prostatis take Jardiance or Farxiga?
I think they mean prostatitis, which is a chronic infection of the prostate gland. I would be concerned about administering an SGLT2 inhibitor, Farxiga or Jardiance, to such a patient. Not to say it's impossible, but these agents increase the risk of developing a urinary tract infection or an infection in the groin, in the area of the genitals. And that's because your urine now has a lot of sugar in it, because they block the kidney's ability to reabsorb sugar and keep it in the bloodstream. So it ends up in your PP. And when there's sugar in the PP, bacteria and funguses and yeast can have a party. So I'm personally very cautious. I take a urological history. And if someone has had recurrent urinary tract infections, I'm very reluctant to prescribe one of these agents, because here you are trying to prevent a problem, which is the underlying disease, from getting worse. But you could introduce a life-threatening urinary tract infection that could enter into the bloodstream and really be very harmful. So it's an individual discussion, but that would make me personally very concerned about administering the medications.
Okay. Alan is taking both furosemide and Jardiance. Should he be taking one versus the other? He seems like he heard Jardiance is favorable. Also, any problems with taking both?
No problem with taking both. I think the message is one of the reasons to consider using one of these agents, that is Jardiance or Farxiga, is to take less diuretic. Some people, when they start it, can get away with taking less diuretic. And our on average data I showed you is that the dose of the diuretic could be reduced in everybody by about 25%. Were there some patients who needed more diuretic while taking Jardiance and Farxiga? For sure. Were there some who needed less, some who didn't need a change? So you can't come up with a hard rule for everyone. Everyone reacts differently. But in general, the dose of diuretic, at least in our center, is reduced by about 25% in people who start Jardiance or Farxiga.
Okay, someone emailed in a question. I have irregular heart rhythm, AFib or atrial flutter or tachycardia with no symptoms. Is it worth treating it with cardioversion and ablation or beta blocker with no improvement? Should it be left alone?
I think this comes back to the kind of what we were saying this, where I'm assuming because in amyloid, I always tell people the heart's like a house with 2 top rooms and 2 bottom rooms, right? Those 2 top rooms become big and stretched. So the nidus for rhythm abnormalities, which are electrical problems in the heart, particularly in those top chambers, is never going to go away. So very high risk for atrial fibrillation, atrial flutter. Whether or not you try to get out of it largely depends on kind of where you are in your amyloid journey. Also, if it's the first time you've had it, it's probably worth trying to get out of it. Do you need additional help like an antiarrhythmic or something to stay out of it? Those are tough discussions, right? And really are a case by case basis. And again, the same kind of discussion with ablation. Again, we tend to think if you're earlier on in the amyloid journey, the biomarkers like the BNP are on the lower side. You're not getting admitted for heart failure. You're not on high doses of diuretics. You have a better chance of staying in a normal rhythm. So if it's early, I would say yes, probably worth a cardioversion. And trying to get out of it. If you're in it and you've been in it for 5 years, no, absolutely not. I would not put you through it. And always making sure you're on a blood thinner is the key to prevent a stroke.
Okay. Thank you. All right. Well, Dr. Karam, you answered this. What therapies to treat dizziness, balance, palpitations? Well, you answered some of it. So we'll give you this question again. Okay. What therapies to treat dizziness, balance, palpitations, anxiety, shortness of breath? Because I realize that anxiety is a whole different ball of wax than dizziness and balance. So we'll throw the ball in your court there.
So for the dizziness, it's important to determine where it is coming from. Is it coming from the ears? Is it coming from the blood pressure issue? Is it coming from the brain? So dizziness can mean a lot of things. So clarifying what exactly is meant by dizziness, and if the person is having trouble, maybe doing, blood pressure, sitting down and standing up, see if it's dropping, doing some maneuver to see if the ears are dysregulated, which can also happen, and so forth. So this is number one. Always try to figure out where is the problem coming from, because the management is completely different. So that's number one for the dizziness. For the imbalance, same thing. Is the imbalance coming from the nerve? Is it coming from the brain? Is it, and so forth. So careful history and examination, followed by perhaps imaging, is very important to determine where is the problem is coming from. I would not answer that, oh, you should do this or you should do that before exactly knowing and being certain that the problem is coming from that area. And then for the anxiety, obviously, there's a lot of things you can do, breathing exercise, meditation, talk with a therapist. And obviously, if all of these fail and you need medication, then that would be the route. But I always people are already on multiple drugs. So I try to reduce the number of medication they're on rather than increase the medication. So a lot of time being self-aware and breathing and doing different meditation and cognitive behavioral can help with these symptoms.
Okay, I'm aware that the time is closing in on us a little bit, but if I can ask our wonderful physicians to stay on another few minutes to answer another few questions, that would be really great. Dr. Karam, is there any connection between normal pressure hydrocephalus and ATTR wild type?
So both are problems that happen as we get older. So I'm not really sure they're necessarily caused by the amyloid. However, pressure in the brain can increase if there's amyloid deposition around the leptomeninges. So I'm not going to say that's for sure, and I'm not even sure this has been reported yet. And it's going to be very hard to prove, obviously, without doing biopsies of the kind of tissue around the brain to determine if there's amyloid deposition. Because unfortunately, imaging is still not good enough to determine if there's amyloid in the brain or not coming from TTR. But I would probably guess that these are two, not common, but these are two problems that happens as we get older, and it's probably just chance rather than cause. I could be definitely wrong. I don't think this has been studied extensively, but good thought. I mean, same thing with Parkinson. So we see Parkinson and wild type, right? How do you know? You know, people as they get older, they get Parkinson. So it's very hard to prove what's what. And wild type is really common. You know, old studies have shown that these were talked about 20 years ago. 25% at least of people over the age of 85 have deposition of wild type without necessarily having symptoms. So wild type is just common. That's, I think, we cannot blame everything on wild type, or maybe we could, but I don't know. It's a common problem as we get older. You know, you can find it in various tissue. If you get a prostate biopsy, if you get a, you know, different things. If you send amyloid, there's a big chance you're gonna get it these days. So, and then you're stuck with it. Sorry, off topic here.
Okay.
Fascinating though. You know, if everything can be explained in wild type, then that we can explain a lot of things as we get older. There's a lot of problem that happens as we get older.
Tell me about it. Okay. Okay. A hereditary patient just asked the question, is there any way to diagnose that amyloid is the cause of hearing loss?
Yeah, that's another thing. So we you know, a while ago, that was maybe, you asked me to talk about central amyloidosis. That was maybe 6 years ago in one of the biannual meeting. So hearing, vision can be impaired, and it seems to be more common in people with amyloid, and there's evidence that there's amyloid deposition in these organs, the eyes and the ears. Can we actually prove? Unfortunately, no, we don't have any specific tests to prove that. You know, unless you undergo an autopsy, that's, you know, we don't want to do that. But yes, definitely these can be associated, and there seem to be a higher incidence of hearing loss with people with amyloid.
Okay. Okay, so if a person, I'm going to ask all three of you this, okay? And I really need your real thoughts on this. So Dr. Karam, you're in there right now, so I'm going to ask you. Okay, this patient has been on Vindamax and Amvuttra, but insurance now says one or the other. Okay, Dr. Karam, which one?
Well, so it depends what they have. If they have neuropathy, what's approved in the United States is Amvuttra and not Vindamax. I'm not saying that Vindamax wouldn't work. I'm just saying that this is what's approved. So if you want to stay on label, if you have a mixed phenotype, then Amvuttra is also approved for both cardiomyopathy and the neuropathy, whereas Vindamax is not approved for the neuropathy. Now, if you have very mild neuropathy and the main issue is the heart, then you can stay on Vindamax, whatever. I think that's a discussion to have. But I do really think that being on one is important. Being on two is probably doesn't have much added benefit that we would be able to detect.
Okay, so Dr. Maurer, would you have a preference of Amvuttra or Vindamax if a patient has to drop one?
Yeah, I agree with Karam, Dr. Karam. I think you need to know the details of that particular patient, but there's, reasons to think of one or another under certain special circumstances, but it requires a discussion with the provider, and I don't personally have a preference.
Dr. Sarswat, do you have a preference?
No, I completely agree. It's a case-by-case basis, depends on their symptoms, what's better for them and their family. And I mean, these are real discussions, especially with the hereditary patients. I think there are people that were put on, a silencer initially and a stabilizer for cardiomyopathy, a silencer for neuropathy, and end up on both, even though that was maybe, now and with data that was not the intention. And once we realized that Amvuttra was good for both, we have these discussions, and truthfully, most patients don't want to stop one, even though we know that Amvuttra it can be for both. I find it very rare that anybody is willing to stop as long as their insurance covers. So what we end up doing is having a discussion just like this and saying, well, if the insurance comes after us, let's pick one and let's decide for you. So we have a plan in motion that if we get into trouble, we know which one we prefer. And that's again going to be based on, presence of neuropathy, presence of autonomic dysfunction, and preference for pill versus injection.
Great. Okay, I've got 2 more questions, and we can't thank you enough for giving us your Sunday. This means so much to all of our patients. It's really great. So we'll take one more here for the cardiac. How often do patients in general need a cardiac MRI?
I personally don't think we know how often MRI should or should not be done. There are centers in the world that do them as part of routine, potentially as frequently as every 6 months. Not sure if that's all part of clinical care or research. I don't know what you would do with the MRI information at this particular point in time. I guess it would be great if I could tell you your ECV was going down. Probably be a little bit less well if I told you your ECV was staying the same. But if I told you your ECV was going up, you'd ask me as a patient logically, well, what do you want to do about that? And right now the answer is I don't have a proven therapy to address that. So I urge patients to think about testing that can meaningfully change the direction of their care and what's going on. I don't know that imaging personally does that at this point, despite everyone's desire to know more. And there's a lot of heterogeneity. I think in the US, it'll be very, very hard, given insurance companies, firewalls or whatever they do to get routine imaging done on any set basis. But I'm curious to see what my colleagues do at their center.
Dr. Sarswat?
Yeah, I agree. I mean, we don't certainly do MRIs on everybody, and I think there's lots of people that don't need them at all right now based on the data we have. I think it's very interesting, and I think we're still learning. And if a patient is willing to undergo an MRI and we think it's going to change management, that's a different story. But I also think a cardiac MRI is not a fun test, right? So exactly like Matt said, let's not put you through it unless it's going to affect something, if it's going to change how we manage things, change medications. And right now, there's nothing really on an MRI for TTR that's going to focus, tell me I need to switch from a stabilizer to a silencer or anything. There's nothing there, right? Because again, when you think about the mechanism of drugs, none of these are causing reversal clear that we know of. There's some small data that says, okay, your ECV goes down with acoramidis. This is like a couple of patients, right? Maybe 5 or 6 patients. There's nothing that I can say I'm going to make a big change on with an MRI. But I think where it will come into helpful, where it will be helpful is when we talk about the depleters. Again, we talk about the monoclonal antibodies, the antiviral therapy, as we're potentially causing removal, but we're not there yet to use that in everyday clinical practice. And it's just, on a lot of patients, just not quite worth it to put you through it.
Hey, well, again, thank you, everyone. If you're lucky enough to have Dr. Maurer treat you in New York, or Dr. Karam in Pennsylvania, or Dr. Sarswat in Illinois, you can see how lucky you are, right? But there's wonderful doctors all over, thank goodness. Not like it used to be back in the day, right? We want to thank all of our presenters. And again, this video of the meeting will be up soon. I'll send everyone a link so you don't have to email me and say, when is it available? I promise you, as soon as it's available, you'll be the first to know. Remember, we do have a survey. We beg you to fill it out. And we do have Facebook groups, and I'll send you information on that as well. No one ever has to feel alone here. I want to thank Bob and Paula for all their help. And Monica had to leave, but we want to thank her as well. We're very lucky to have all of you. And thank you again.